I'm happy to welcome everyone to this year's clinical meeting. We are happy to have Dr. Rao as our moderator for this session. So has been part of our institution since 2014, working in the lifestyle medicine department. He's very passionate about whole care, whole person care, working towards lifestyle-based approaches towards disease prevention and reversal. So we're very happy to have you here, sir. Welcome to you, everybody, to this session.
Our first program this morning will be by Dr. Praneet, Brainstorm.
Good morning. So this is I'm from Medicine 5. So this is Mr. M, a 38-year-old auto driver from West Bengal who had presented with hollow cranial headache and low-grade fever for 2.5 months. And he had multiple episodes of GTCS with posturing of all 4 limbs with post-ictal drowsiness for past 1 month. And then he had also complained of altered behavior, which was irreverent speech sounds. He was restless, agitated, and he had incessant crying spells for the past 25 days. He was admitted in West Bengal in government hospital Bankura, where a CT scan of the brain done was normal, and a CT thorax done was also mainly normal. No MRI was done. No lumbar puncture was done. He was treated as a probable meningoencephalitis with our antibiotics injection, ceftriaxone, antivirals, acyclovir, doxy, levetrestam. Because of seizures, he was given carbazepine, and because of this altered behavior, he was also thought to have a underlying psychiatric illness, for which he was started on various psychiatric drugs such as citalopram and antipsychotics like risperidone, promethazine, but there was no improvement. He's a known chronic smoker for the past 20 years. On examination, when we've seen him, he was awake, but he was irritable, he was not oriented, and he had crying spells during examination of the casualty, and he had a vacant stare, unable to follow commands. Vitals wise, he was tachycardic and had a borderline blood pressure of 90 by 60 meters of mercury. His GCS score was 11. There was no very prominent features on general examination. System examination, CVS, RS, and abdomen were normal. Coming to the CNS examination, cranial nerves, pupils were bilaterally able to, and reactive to light fundus was normal bilaterally. Cranial nerves which could be assessed were mainly within normal limits. Motor system, he had increased tone in the lower limbs, and power basically was difficult to assess, but there's minimum at least 3/5 in all 4 upper limbs and lower limbs. Sensory system could not be assessed. Reflexes were exaggerated in the knee and ankle, and plantars were bilaterally extensor. The gait couldn't be assessed, and he had neck stiffness that was present. So coming to the summarizing, this is a young gentleman who had presented with headache, fever, and altered seizures and altered behavior, and on examination had features of neck stiffness and some exaggerated reflexes in the lower limbs. So, and this is a prolonged history for around 2 months. So our first thought was an infectious etiology, viral encephalitis, possible HSV or a Japanese encephalitis virus sequelae, TBM. Others were malignancy, autoimmune like encephalitis, CNS vasculitis. Other lower down possibilities were a paraneoplastic syndrome, since he was a chronic smoker. And then lastly, because he was having prolonged seizures, was it an HIE or a post-ictal state? On investigating, he had elevated leukocytosis with left and some mild thrombocytopenia. CRP was elevated. Electrolytes within normal limits. The CSF done showed, this should be highlighted. It was 14 cells elevated with lymphocytes predominant 94. Glucose and protein were within normal limits. Culture sent were negative for a bacterial culture, multiplex PCR, cytology, as well as TB, and also viral multiplex, and especially JE virus as well. Autoimmune workup like ANAs and all, ANA was also negative. Finally, because all our cultures were negative, and he had some lymphocytic pleocytosis, had considered a possibility of an autoimmune encephalitis, for which we had sent a panel in the blood, and that showed 2+ positive NMDAR receptor. Our imaging done, CT, MRI brain with contrast, and MRI spine also, because he had some increased tone and in the lower limbs with reflexes, showed no significant abnormalities. So our final diagnosis was that of a syndrome, was that of a fever with headache followed by seizures and altered behavior with nuclear rigidity. Our clinical localization was that of meninges, because of these, along with parenchymal involvement because of seizures. So our final diagnosis that we reached after everything else was negative was an autoimmune encephalitis. Just quickly running through it, it's a very wide topic which we're not very well aware of because we don't see too many of these cases. Diagnostic criteria is basically when all these three of the following criteria have been met. It should be a subacute onset of less than 3 months of patient complaining of mainly memory related deficits, altered mental status, or psychiatric symptoms. He should have at least one of the following: any new focal CNS finding, seizures not explained by seizure disorder, a CSF pleocytosis, and MRI features suggestive encephalitis. And then it should be a reasonable exclusion of other causes. Similarly, this is for in specific, I'll be talking about NMDA receptor encephalitis because that's what our patient had. This patient also should have less than 3 months onset of at least 4 of the following 6 symptoms, which is abnormal psychiatric behavior or cognitive dysfunction, speech dysfunction, seizures, abnormal movements, low sensorium, and autonomic dysfunction. At least one of the following laboratory results, such as abnormal EEG, in particular an extreme delta brush, CSF with pleocytosis again, and other exclusion of other disorders. The pathophysiology is basically for autoimmune encephalitis, there are antibodies which act on, there are two groups of distinct groups. One is the antibodies are intracellular directed, and second is there is cell surface directed, which have both clinical imaging features. These neuroimaging features mainly involve the limbic structures. But that is classically seen in autoimmune encephalitis, but there can be involvement of other structures as well in probable autoimmune encephalitis. Most of the patients will have neuroimaging findings, will have no neuroimaging findings despite profound neuropsychiatric dysfunction. In particular, the disease that we are looking at in NMDA, the patients will present with usually psychosis and abnormal movement disorders. So this encephalitis is one of the most common and most characterized subtype of AE, usually seen in women and children. It starts like a viral-like prodrome, like what our patient had: fever, headache, and followed by more severe symptoms, psychiatric symptoms, schizophrenia, psychosis, and can even lead to profound respiratory depression, coma, seizures, ultimately, and then lead to severe neurological deficits. This is usually some of the imaging features that we've seen in usually an NMDA receptor encephalitis in a woman. So usually we'll be seeing this limbic area will be involved. Most commonly, left inferior temporal lobe, and other areas that can be involved are that of the cingulate gyrus. So one unique feature is that most of the patients are unlikely to have any neuroimaging abnormalities like our patient, and this is consistent. Another study has shown that 66% had normal brain imaging findings and 44% had some T2 flare hyperintensity. Compared to MRI, PET CT is more sensitive to picking up these early changes. With early diagnosis and treatment, these have a good prognosis and they can be complete resolution. For some NMDR encephalitis, there are proven ovarian teratomas and malignancies that were found later on, especially that of an ovarian teratoma. So in women, so it's important to screen for an underlying malignancy regardless of the antibody profile. And so just a short algorithm. So how do we suspect this? So we have to do a brain MRI imaging and see if there are any findings, but we might not often find one. EEG, which can have those characteristic changes of the delta brush and slow hemispheric waves. Then you can confirm the etiology by performing an LP, which will show pleocytosis. And also we can send autoimmune encephalitis in this as well as in the blood, and also onconeural antibodies to look for any paraneoplastic syndrome. And then once we find out diagnose the patient, we need to screen like either a focused or a body PET if the screen is negative. In particular for NMDAR, we should do a pelvic or testicular ultrasound because this is associated with ovarian teratoma or a seminoma in a male. Diagnosis characteristically is an MRI, which shows bilateral limbic encephalitis. EEG can have non-new onset refractory status epilepticus, and occasionally the delta brush, which is seen in specifically NMDR associated encephalitis. CSF findings can show lymphocytic pleocytosis. So just a short treatment. What we usually so after we diagnosed, we had started our patient based on neurology opinion. We had pulsed him with IV methylprednisolone for 5 days. So that is what is commonly given. You can also give a combined therapy, which is IV methylprednisolone along with IVIG. And we wait for the patient to respond. If there is no response within 4 weeks, then we have to usually add a second line. Options are rituximab versus cyclophosphamide, of which rituximab is the most common because of a relatively safer profile. Again, just to focus on the right side, tumor. So if there is no tumor present, it's possibly an idiopathic AE. which can be NMDAR, and consider starting the patient with IVIMP and IVIG or PLEX. And there is no improvement, we should go for a second line agent rituximab. We should also screen, not forget to screen for neoplasms associated with this, most commonly small cell lung cancer, testicular teratoma, lymphoma. And like I was saying, specifically for the pelvic ultrasound for NMDR associated. If there is no response, then we should start rituximab and cyclophosphamide. So it is important to detect, because this is, if you treat the relevant tumor, it can help the autoimmune disorder. Both can be given simultaneously in a coordinated fashion. And one important thing to remember is, if the diagnosis is that of a lymphoma and then you have an AE, treatment with steroids and cyclophosphamide, which is classically used for AE, can alter your lymphoma. So we should diagnose the thing first, and then also screen, make a primary diagnosis, and then take the patient.